Welcome to Maryland Health Today. I'm Ellen Beth Levitt. Blood clots and other types of blockages in the arteries or veins in the legs can have serious health consequences. On the show today, we'll talk about the symptoms and treatments for deep vein thrombosis and peripheral arterial disease. My guest is Dr. Ziv Haskell. He's the Chief of Vascular and Interventional Radiology at the University of Maryland Medical Center, and Dr. Haskell is also a professor and vice chairman of diagnostic radiology at the University of Maryland School of Medicine. Welcome to the show.
Thank you.
When we take a long airplane ride or a long car ride, often we hear advice to stop and get up every once in a while, walk around. Why is that?
Actually, we'd like to prevent the development of a deep vein thrombosis, or a DVT, which is a blood clot that often forms or can form in your calf or even in the thigh from immobility, from sitting still for those long holiday rides or plane rides.
Why is it called deep vein thrombosis?
Well, most of them happen in the leg, although some in the pelvis, and there are two sets of veins in the leg. They're the superficial ones, the ones that we often think about as causing varicose veins, but the deeper system that isn't visible is the one that can develop the clots, and those, the feared complication, can potentially break free, move to the lungs, and that's the pulmonary embolism.
So that's why it's considered to be a dangerous condition.
A pulmonary embolism, a clot that's traveled, in fact, can be life-threatening.
How common are these?
There are more than 500,000 patients who are affected by this, and there are perhaps more than 100,000 deaths attributed to deep vein thrombosis and related pulmonary embolus.
You mentioned that the clot can go to the lungs. What happens when it goes to the lungs?
When it travels to the lungs, you can obstruct a small or even many, depending on the size of the blood clot, branches that supply blood to the lungs. In other words, blood leaves one side of the heart, gets distributed to the lungs to get reoxygenated, and then gets sent back through to deliver oxygen to all organs, all muscles. And that blockage reduces that ability for blood flow to travel, and actually can so substantially reduce it in large blood clots that your heart is essentially pumping against an obstruction.
Is there a risk that this deep vein thrombosis, or rather the clot, could go to the heart or the brain?
It's a great question. It turns out that there are multiple plumbing systems, and there are arteries, and the arteries are the ones that actually blood clots can go or travel or form in, those that can cause stroke. And heart attacks are usually blood clots in arteries as well, the coronary arteries, and this is primarily on the vein side.
And it doesn't go up, so it would stop in the lungs.
And it actually travels through a different side of the heart on the way to the lung. So it does, if you will, a drive-by past the heart on the way to the pulmonary or lung arteries.
What would be the symptoms of deep vein thrombosis?
They're varied from the most dramatic ones, which is a sudden and marked leg swelling that can affect the entire thigh and calf. There can be some skin discoloration, a sense of tightness in the calf that may just be asymmetric. You feel like one leg is aching, like you had a Charlie horse or something like that. Your leg may become more painful when walking or fatigue more easily. And some of these signs are actually a bit subtle, which are concerning because, as we said, this can result in a very serious illness.
Are some people more at risk for deep vein thrombosis than others?
There are patients who have higher risks, and there are patients who have, perhaps until their first DVT, an unrecognized thickening of their blood. In other words, it's more prone to blood clotting than other patients, and very often in a young patient, a DVT is the thing that triggers all the blood tests that try to identify the hypercoagulable, excessive blood clot forming conditions, but also recent operations or obesity or long immobility like train rides and that typical holiday travel.
And even pregnancy can raise your risk?
Certainly. A pregnant uterus can compress those veins and increase the pressure returning up from the legs, and that reduced flow can make blood more prone to clot.
How do you diagnose a deep vein thrombosis?
Well, the first and most important thing is what we said, which is clinical suspicion, being aware, getting to your doctor. And then the most typical first test is actually an ultrasound, a non-invasive test, which is excellent at looking at the veins to see if there are blood clots.
And if you have any of those symptoms, should you get to a doctor right away? Should you go to an emergency department, or should you call your family doctor? What should you do?
I think all of those are great possibilities. I think any doctor should be able to think of this diagnosis and refer you, if suspected, to an ultrasound department, a radiology department, a vascular lab to be able to have these diagnostic studies.
Right. You mentioned that about 600,000 DVTs occur every year, and as many as 200,000 people die from pulmonary embolisms that result from these. So it sounds like very, very serious.
And of course, many of them are patients who are very ill in hospital and have that develop on top of other illnesses as well. But for us, sort of the walking and relatively healthy as well, these kinds of conditions can occur as well.
So how is it treated? How is a deep vein thrombosis, once diagnosed, treated? Well,
there are a couple of important pieces in treating deep vein thrombosis. And first is preventing the pulmonary embolism, the blood clot that has moved to the lungs, or minimizing the effect of that, preventing the next one if you survive the first, preventing the second, and also in terms of minimizing the symptoms to the actual leg. Most of them start in the leg. So blood thinners work very well at reducing the risk of having a second pulmonary embolus or more blood clot forming in that leg.
How long would someone be on blood thinners then to treat this?
Well, typically a minimum of 3 to 6 months for a deep vein thrombosis. So it is. And in that time, the blood clot hardens and eventually heals to some degree. And that's very effective at reducing the risk dramatically of a pulmonary embolus or a second one. It doesn't entirely, though, affect the limb. And that's been a change in how we have been thinking about treatment of deep vein thrombosis in the last years.
Would taking aspirin help if someone thinks that they might have this condition, popping a couple aspirin?
You know, an aspirin is very important perhaps if you're having a heart attack, and that's the coronary arteries, but I don't think that there's any clear evidence that that as your first treatment is the thing to do for DVT. I think the thing that you brought up, which is an early suspicion and reaching your emergency department or your family doctor, is really the best way to go.
Right. And then in terms of treatment and so forth, you were saying that the blood thinner takes care of the clot, but people can still have continuing symptoms in their leg, maybe some pain or some swelling, or there could be something going on in the vessel itself that should be checked out?
And our medical term for that is post-thrombotic syndrome, which means a syndrome of things that happen after you've had a blood clot. The thing that, in fact, many doctors don't realize as well is what a blood thinner does is it prevents development of new blood clot or it breaking free, but it doesn't, in fact, dissolve a blood clot. You depend on your body to dissolve the blood clot in your leg, and that may take weeks. And what we haven't realized is, in fact, the weeks that it may take, if you're so lucky as to even dissolve it yourself, actually wreak havoc on the veins. The veins become damaged and often permanently scarred, and that results in the symptoms of the post-thrombotic syndrome.
So I guess for treatment of that, that's where you as an interventional radiologist would come in?
Yes, and the symptoms of post-thrombotic syndrome, and I think they're far more common and they occur much faster than many of us realize. This is not something, as I was taught in medical school, is in some distant future, 10 or 20 years away, but can happen within months of a DVT. And what you can have is a leg that may potentially be abnormal for the rest of your life. Leg is swollen, leg is fatigued, leg that behaves differently than the other one with prolonged standing, type of thing that you might not stand in the long line to buy tickets for because that leg feels different and may be permanent. As an interventional radiologist, and it's an unusual term. In fact, we say that even our mothers don't know what we do for a living. We're the specialty that does image-guided treatments with tiny little tubes. We treat a lot of conditions ranging from peripheral arterial disease to uterine fibroids to targeted therapies for cancer to DVT using tiny little tools and imaging instead of operations and incisions.
Right, so you go up through a blood vessel and watch what you're doing on different imaging.
A moving X-ray camera or an ultrasound, or in some occasions, perhaps more in the future, even under MRI guidance.
So what are we seeing here? Is this the typical setup for an interventional radiology laboratory, I guess, as it's
Yes,
called?
exactly. In this case, we're looking at it at a fluoroscopy suite, and that big round camera over the top, and there's some monitors so we can measure a patient's blood pressure, make sure that they're relaxed. Our patients are typically awake. They don't need to be asleep, just relax for our procedures. But what you saw was a very large camera that allows us to see something moving inside. And it's almost like video games in the sense that we can move something with a very small tube and have it have an effect in another location on the body. So we can do, if you will, very large treatments through very tiny little pencil tip sized holes.
So how do you treat these clots in the veins, in the deep veins? What do? You go in there and break them up?
Right, so the object really is to not have to wait those many months for the blood clot to potentially dissolve and have the damage occur to the vein walls and the little valves that prevent blood from going backwards in our legs. We have a number of devices. We're seeing an animation of one particular one on the screen, which is a tiny little tube with these small balloons on the end that allows us to put some clot dissolving medication, very different from blood thinners. Actually chews it away. Think of it as if it's like a Drano for blood clot, and this little spinning device that will break it up into little things, and that together with the clot dissolving medication, TPA, the same type of clot buster that we'll give to someone with a heart attack, allows us to then suck it out, actually, and draw it out through this tiny little tube.
I was wondering if there were little pieces of clot left behind, but it looks like this actually, the system sucks the little pieces of clot into the tube and whisks it away.
And it turns out that for veins, we're tolerant of having little bits of blood clot like that. And I've actually brought a couple of examples of some other types of tools that we have. And here's another example of a catheter. You can see how small it is and how flexible it is.
Yeah.
And we can put this in as if it were a small IV and thread it up into a patient. And it has a giant pump that's connected to the very back of it that allows us to actually spray and suck blood clot out of it. Here's another newer device that has come out, which it's a little bit hard to see, but if you can see this little bowstring wire over here, this is actually an ultrasound vibrating wire, and very high-speed ultrasound vibrations of this wire, too fast to see, will actually create tiny little shockwave bubbles that will also break up blood clot. And again, a very, very small tube. Often these procedures are done potentially even on an outpatient basis through an IV that we start from behind the knee. We go upstream from this and then use these devices with the clot-dissolving medication to clean out that vein. And after one session or possibly two, a Band-Aid on the back of the leg, and then, of course, the blood thinners. You still need the blood thinners to prevent return of blood clot. But the idea is that by getting rid of that blood clot early on, when it's soft and removable, very easily you prevent the damage to those veins that leads to that disabling abnormality, the post-thrombotic syndrome.
How would someone know if they need to have this interventional radiology procedure in addition to the blood thinners? Are there certain people who are advised that they should have it more than others?
Well, this is something that I and people in my field have been doing for a long time. I've been working actively in this for over a decade with clinical trials and investigations, looking for ways to actually make this faster and easier on patients, and not what it used to be, which was a much longer procedure, but really a one-day, possibly even go-home-the-same-day procedure. But there's still a communication and information gap between primary physicians or emergency rooms and the knowledge of the availability of these types of things. And to be honest, many of the patients who've come to me over the last 10 years have all been self-referred. They've gone out and they've looked on the internet, with 80 other million Americans who use the internet for information, because they don't necessarily have physicians who are aware of this. So I think part of this is just being aware of what your options are.
Okay, great. Well, we have to take a break, but when we come back, we'll talk more about some of these disorders in the veins and arteries, and we're going to focus on peripheral arterial disease. So stay with us. We'll be right back.